Nowadays, developed healthcare systems provide a wide range of publicly funded services to patients. These services have developed over long decades, and while many of them, for example hospital care, already existed 60, 70 years ago, some of them have been included in the service package relatively recently. Modern diagnostics or medical devices, for example. Let's have a closer look. Modern healthcare systems provide various public health services to citizens, such as screening programs, prevention, including one of its most prominent components, vaccination, health education, and other services. Yet for most people in their everyday lives, primary care is the most common point of contact with healthcare. General practitioners, pediatric care, and dentistry care all belong to primary care in full or in part. One level higher in the healthcare service hierarchy is outpatient care, which is essentially specialized care not requiring hospitalization. Ambulatory centers for specialist visits, sometimes called outpatient clinics, and most diagnostic services are components of outpatient care. In a broader interpretation, on-prescription pharmaceuticals and medical devices also belong to outpatient services. Services requiring shorter or longer hospitalization are collectively known as inpatient care. It comprises a wide range of institution-based services from one-day surgery through emergency wards and active care to diverse types of chronic care. As a general principle, the higher we go in the hierarchy of services, the more complicated and resource-consuming the services are. One of the most challenging issues in healthcare is to find proper and working methods for financing all these services. Financing, often called funding or reimbursement, can take different forms for different services, and there are hardly any perfect financing forms. We will now look at some examples. Primary care itself can be funded via various financing forms. This slide shows 4 different logics. These are arranged vertically in the first column. In the first possible logic, detailed service catalogs. General practitioners invoice the payer for each item of service they provide to patients. In the second logic, fixed payments with adjustments. GPs receive fixed payments per period with individual adjustments to allow for experience, location, population size, and other considerations. In the third logic, capitation payments. GPs are remunerated based on the number of patients registered with them, or without individual adjustments for experience or location. Finally, the fourth logic, performance pay, means that GPs are remunerated based on their performance as measured by some care quality indicators, such as vaccination rates, patient complaints, participation in special programs, and so on. This financing logic is usually complementary to other logic, typically capitation payments. As you can see, each of these logics has its advantages and is associated with certain challenges. These are shown in the second and third columns, respectively. To get an idea of these, please pause this presentation now by clicking on the pause button so that you can read this slide. When you have finished reading, please click on the play button to continue the presentation. Outpatient care and inpatient care are often financed through standardized tariffs called diagnosis-related groups, DRGs. Although DRG systems in practice can be rather complicated, their core idea is quite simple. Their starting point is that each patient and each case is different, but it is possible to form relatively homogeneous groups of standardized, condition-specific healthcare interventions called DRG codes that will receive the same amount of funding. DRG codes are collected and published in so-called DRG catalogs, which also assign scores to each DRG code. The actual value of a DRG code will be the multiple of its score and the actual base tariff. The base tariff itself is modified every couple of years to account for inflation in healthcare. This slide shows an example for the calculation of the value of a specific DRG code, coronary bypass surgery with catheterization. By multiplying the score of this intervention, 11.746, by the base tariff, €500, The actual value of this DRG code results as €5,873, uniformly for all patients undergoing this intervention. Finally, the system of pharmaceutical and medical device provision shows an example for a very different funding logic. In this system, the core document is a prescription given by the prescribing physician to the patient. When the patient fills the prescription at the pharmacy, they only pay the required copayment. The remaining part of the price of the medicine or medical device will be transferred by the payer to the pharmacy directly.